Good evening, you're watching Faye Live with Faye. I apologize for the slight delay in starting the show, but we're here now, and there's a very important conversation we must have. And I know that there seems to be a reluctance to having this conversation, but the news should be about what is important and not what is exciting. This is what is important right now. As I've been saying over the last several weeks, there are three very important developing stories in our country right now. First of which is the COVID outbreak, which is nowhere near under control. Second is the economy and the job loss. And third is India's relationship with China and the escalating tensions at the borders in Ladakh. Today, we're going to focus on story number one, what's happening with the COVID outbreak in India and why it's something that we should be very worried about. Let me take you through some of the numbers we've had. Look at that graph. I mean, to forget about flattening the curve, we haven't even reached the curve yet. Right now, it's just moving upwards. And it's been a terrible, shocking week for those people who are tracking the COVID numbers in India. And unfortunately, that's a very small group of people. On Monday this week, we overtook Brazil and to become the second worst affected country in the world as far as COVID is concerned. After that, we have added 3 lakh cases in just 4 days. We are now at this rate on our way to quickly overtaking the US as well and becoming the worst affected country in the world at about 4 or 4.5 weeks. That's how long it will take at this current rate. On Thursday, we recorded 96,551 new cases, a fresh global record for any country in the world. We seem to be beating our own record on a daily basis. More than 76,000 people have died in India so far, and an average of about 1,000 people are dying every day. That is a depressing and distressing number. 1,000 people are dying every day in our country. And for those people who argue with us and say, oh, look at our population, this will happen because of our population, I want to first remind you that there's 1,200 families who have lost loved ones just today. And then the day before that, and the day before that, and the day before that, and we don't look anywhere near solving that problem. But let's take a look at what's going on and the details that are emerging and why I believe this is, like I said, worrying. Now, the government has been arguing that we see larger numbers because we're testing more. It's a ridiculous argument also because the ICMR has released its first nationwide serological survey that suggests more than 6 million people were infected with COVID as early as May. That means we're well ahead of the US already. It has nothing to do with testing. Failure to communicate the seriousness of what's happening right now by government and media and the need to open the economy has resulted in people taking this very lightly. They're walking around without social distancing and without masks, and that's making things worse. Now, 2 more things have emerged. Doctors in 6 locations in India have recorded reinfections, which means someone who had COVID, they say, and recovered, has got it again. Incidentally and disappointingly and worryingly, in many cases, the patient is a doctor. Studies are also showing that COVID could have long-term lung and heart damage, and that should worry those people who think that, okay, if we get it, we'll quarantine ourselves and then we'll be fine. Even young people are suffering. There is a worrying report from the New York Times that says that the virus might also be affecting brain cells, and it is showing some symptoms there as well. People are showing symptoms like delirium and confusion, scientists have reported. And the last thing I think that we should worry about is delays in the vaccine. The Oxford vaccine, which was the front-runner vaccine, has actually paused its trials after one participant fell very sick. Trials have been paused in India for that vaccine as well. In the meantime, hopes are now being hinged on Russia's sovereign wealth fund's Sputnik V vaccine, which has now said that they will make over 1 billion of these vaccines before 2021. But we'll try and find out how far away the vaccines are. And we've got the best guest we could possibly put together for this conversation, which is great because nobody else is talking about this topic. So the best minds are available for us. So that's a benefit for my audience. Today we have Dr. Shahid Jameel join us. He is a top virologist and a very trusted name in this particular matter. Dr. Tanmay Mohapatra is an epidemiologist who's been kind enough to talk to me through the course of the lockdown and the outbreak. Professor K. Srinath Reddy is the president of the Public Health Foundation of India, and Dr. Shruti Tandon, who will join us in a little while, has been leading the fight at Jaslok Hospital. She's an intensivist. I welcome all of you to this conversation, and I thank you for giving us your time. Dr. Jameel, if I may please start with you. You know, when we spoke earlier, this was worrying. But right now, when we look at the numbers of deaths and the argument that our recovery rate is high, so it's actually nothing to worry about, what part of this data should I be looking at? You know, because a lot of people are taking that literally and just walking out of their houses as if nothing's out there. What's your reading of the numbers right now?
Faye, you're absolutely right. What we are hearing is not the complete truth. We are hearing only half-truths. And the half-truth is that our recovery rate is increasing. Yes, it is increasing. But if you look at it logically, if in India, let's say the death rate is 2%, then the recovery rate ought to be 98%. It's not there yet. We are going to approach that. So obviously, with a 2% death rate, the recovery rate is going to go up to 98%. And it's right now 77 or some percent, yes, like that. So yes, it's true, but it's still far short of where we should have been. The second truth is that the death rate in India is low if you compare it either as the case fatality rate or as the death per million population. But the half-truth there is that it's not just in India that the death per million population is low. India is at 54 per million population today. Bangladesh is, I think, 27. Pakistan is 29. All of South Asia is like this. All of Southeast Asia is like this. So there's nothing special about India. We compare ourselves to US and UK and other Western countries as far as the death rate is concerned, but we don't compare ourselves to our neighbors, which, you know, who have the same sort of genetics, who have the same sort of conditions. So I think this half-truth is leading people into complacency. What we are not telling people is that over the last 2 weeks, India has been putting out the highest numbers of cases on a daily basis than any other country in the world. And if you look at data today, over the last 1 week, India is putting out, on an average, about 90,000 cases per day over the last 7 days. US, in comparison, is putting out about 36,000 per day. They are on a lower, on a falling curve. We are still on a rising curve. So, you know, I think we need to tell everything that's out there to be able to build trust and put out a sense of urgency that people don't become complacent. And all this is happening, I feel, is because people are becoming complacent.
Yes, people are becoming complacent. And the worrying thing also is that we know that this is not as much a Mumbai-Delhi problem. So the media that largely focuses on Mumbai-Delhi has sort of turned its eyes away from the fact that rural and semi-urban India has, in fact, far worse healthcare options than we do in our big cities. But Delhi, we also know, is having some sort of resurgence of COVID, and we'll come to that in a bit. I just want to respond to someone who said the viewership is very low today. Well, I'm not in the race for TRPs. That's one of the pleasures of being an independent journalist. I don't care if the viewership is low. I believe this is a conversation we must have. Dr. Mohapatra, and I want to come to you with this argument that the government is giving us about, because we're testing more, because we're testing about 1 million people a day, that's why we're seeing more cases. Do you accept that argument?
It's a partial truth. That means whenever an epidemiological graph, an epidemic graph is going upwards, we will be getting more and more cases, and the graph, when it is in the exponential growth phase, it will be coming up with more cases, that is obvious. And if we are testing more, we will be able to come up with more positives as opposed to the previous ones in terms of the absolute numbers. That's always true. But the fact is that we are testing more, that is true, and that has to happen. If we see any graph from any of the countries, we will definitely see that apart from the initial days when health system response goes through a jittery phase, after that when the response matures, all the countries started doing the tests more than previous. But the fact is that it is not the whole cause of seeing more cases as opposed to previously, and probably not even the half cause of it. Because we are testing more, that means we are testing more asymptomatics, and we are testing more who actually somehow were not being able to get into the testing process previously because of lack of availability or whatsoever, the guidelines, etc., etc. But the fact is that when we are testing more, we are having both in the denominator and in the numerator. Both sides we are actually having numbers, and in the numerator more, because this is something where we are not having everybody getting positive at the same time. So we will be definitely testing more and going to have more positive cases as opposed to previously in the absolute number. But whenever we are seeing that from the previous day, every next day, we are having the slope of the graph actually increasing. That means we are actually having the spread much faster than before, and that is something expected. We have spoken about this much before. If we look at this graph, we will see that it is becoming steeper to steeper as time passes. And when actually we were listening to a lot of debates in terms of whether we are in the community transmission, etc., etc. We have spoken about those that time, that how prepared are we about it? That was the more important question rather than when we actually entered into it. Because after this ICMR study going to show that lots of lots of asymptomatic and less symptomatic cases were beyond our radar long before than today. So among those cases, spreads continue to happen. And keeping this in mind, whenever we are seeing this many cases coming into our radar, we need to understand that much measured spread around us going on every day. And given the number of given the population size we have, at the point that you just mentioned, the rural areas where the more we test, still there will be a lot of places where we will not be able to reach with the similar intensity of the testing and surveillance. Unless we have a proper nationwide surveillance system which can identify those whom we can identify early and keep in some kind of quarantine or something so that the spread can be stopped, it's impossible. This lockdown, etc., etc., these were only for a period of time, and in a country like ours, it cannot continue for indefinite period of time. But what we learned from that, and during the time, how much we could actually spread our health system capacity into those areas to ensure that ad hoc systems of having people isolated in institution and wherever possible in the at home are being done. Those are important to be linked with this surveillance system about which we are talking for long.
Yes, let me also bring in, if I may, Professor Reddy. Professor Reddy, obviously we know that the spread has now moved into rural and semi-urban India. Are you concerned with the healthcare facilities available in some parts of the country and what patients there might be going through right now?
Absolutely. I think our neglect of rural healthcare, particularly rural primary healthcare, as well as their connectivity to higher levels of healthcare, will actually exact a price. Now, the problem, of course, is that in rural areas, we still have an opportunity which we should not miss. Because when the virus does enter the rural areas, the spread is likely to be slower because of less crowd density, because people also commute shorter distances to work, and there are more open places where they work in. Also, the comorbidities which are likely to be adding greater severity to the disease and possibly culminate in death, those comorbidities are lesser in rural areas compared to urban areas. So having about 2/3 of our population in the rural areas does confer an advantage, provided we don't squander it. And therefore, preventing the virus from disseminating widely into the villages and between the villages is a very important step that we must take. At the same time, we must ensure that we can provide all the health services possible. As has been said, testing is not going to be easily available in the rural areas, but at least on the basis of what we call symptom-based syndromic surveillance, we can actually try and identify who are the people who may be most probably infected, and then provide them the isolation facilities or transfer to a hospital as soon as possible as the clinical condition demands. So we need to work out the strategies for both containing the spread into rural areas as well as providing an appropriate response for management of people who are actually infected in terms of early identification, testing where possible, and the appropriate type of care which is likely to be potentially life-saving.
Professor, what is your reaction right now to people who say that there is fatigue to the lockdown and fatigue to the virus, that life must go on, we must learn to live with it? Because if I'm not mistaken, Delhi is witnessing a sort of resurgence of the virus. It's reporting more than 2,000 cases per day again. Do you think we can afford to have fatigue at this point?
Well, actually, I think the prolonged lockdown did have that effect, but also the sudden release from the lockdown, which gave the impression that everything is now likely to be back to normal, and all the talk about potential herd immunity, all of that sort of gave the impression that people could walk around. So we went from lockdown to laxity at one single leap. And that is the biggest problem that we have seen. At the same time, we are seeing that large crowd gatherings are not really being prevented. And we know that 80% of the infections come from 20% of the people, and mainly from what are called super spreader events, where people actually are there gathered in large numbers with a lot of crowd density, particularly indoors, but even outdoors. So we have not prevented that in any way, whether it is for social reasons or political reasons or religious reasons, we have not prevented that. Secondly, we have sort of given the people the feeling that they can actually move around with a certain amount of impunity. And even when they wear masks, they wear the mask rather poorly, and that is not really helping the cause. So I think the resurgence is both because the policymakers and the administrators have not carried the message strongly and have not imposed the kind of restrictions that are required on crowded events that should have been there. And people too have taken it for granted that they're going to escape from the virus very easily, and therefore they need not follow the precautions.
Some responses from our viewers. Joy Malik, Anupriya Khare, thank you for supporting us financially. We use the money to pay salaries and to continue to do independent journalism that doesn't have to fight the TRP fight. Bharat Rawal says government representatives should at least come to this discussion and answer what they're doing about the pandemic. They don't want to. We have tried. As always, Dips, thank you for the financial support. Going back to the doctors on the panel, Dr. Jameel, if I may please ask you about reinfection. And I'll just share some of the information that we've picked up from various newspaper reports that in Gujarat, 4 people apparently have tested positive again within 1 month of recovery. In Uttarakhand, a doctor has tested positive a second time. In Chennai, at least 10 people who recovered from COVID have tested positive again. Bangalore, 1 person, 1 lady has tested positive again, making it the first case of reinfection in the city. And in Mumbai, we understand 1 doctor may have tested positive again. Is this a concern? Is there, it obviously can't be conclusive, but is there enough evidence to, worry doctors that reinfection is a possibility?
Well, we don't really know everything about this virus, but if we go back and see what happens in other respiratory viruses, other acutely infecting respiratory viruses, and look at the kind of tests that we are using, then, I'm not really very surprised. The other thing to understand is that we are only looking at a few cases like this, and those are also really anecdotal. Uh, Unless you have a sequence for the virus first time and sequence the second time, you can't really say that it's a case of reinfection. If I recall correctly, there was a case in Singapore or Hong Kong somewhere where that was done. So
Yes.
that I would say, yes, that's reinfection. The other, maybe, the negative PCR test was wrong. Maybe the second time when it came positive, you're not looking at a viable virus, but you're simply looking at genomic fragments of the virus. And at the end of the day, we have had for 26, 27 million confirmed cases by now, but you're only hearing about these maybe 10, 20, 50 sort of cases of reinfection. So no, it's not a worry. But then, I will add the caveat that we don't really understand everything about this virus.
But Doc, it's been 6 months that we've been in lockdown. The virus has been around since November, effectively last year. It's a little disheartening that we still don't know enough about this virus.
Well, we know so much more about this virus in the last 8 months. Uh, and a testament to that is 200 vaccines that are already in various stages of development. 46 vaccines are in human trials. The amount of scientific knowledge that is available on this virus today is unprecedented. So, of course, things will take time. As you follow more patients, as you follow them for longer periods of time, you will discover more and more new things. And certainly, this is not an ordinary virus. So, we will continue to discover new things. But let me assure you that uh, science has been a champion in this case. We know so much in so little time.
Faye, if I may come in on this particular point.
Please,
May I?
please, Dr. Professor, go ahead.
Well, there have been two cases, one in Hong Kong and one in the United States, where the genomic signature has very clearly shown reinfection. But as Dr.
Yes.
Jameel said, these are very few cases. But we must also understand what is the basic immunology here. When the virus attacks, firstly, there is the innate immunity that we already have, which tries to fight it. Then there's an acquired immunity in terms of the antibodies and the cellular immune response. They will succeed at some point in time in quelling the virus, but then the antibodies fade away usually in about 3 months. The cellular immunity may last a little longer, but very importantly, they also leave behind the memory in what are called memory B cells and memory T cells, which is almost like the rogues gallery for recognizing an old criminal. So that if the virus comes in again, very promptly the body invokes a fresh response to put them down. Now, the intensity of this response may vary in different people depending upon the level of viral exposure in the first place, as well as their body's ability to produce a good immune response, like, for example, in elderly people, or it could be overwhelmed by repetitive viral exposure of high viral load, like in doctors. But therefore, we understand that the body has mechanisms to combat reinfection. But the most important point is we must differentiate between reinfection and fresh disease, because these antibodies and T cells fight the virus after it has entered the body, but not necessarily when it has entered the nose. For that, you require something called the secretory antibodies. And that is a different kind of antibody. And the current vaccines, which are also being used, are likely to be systematically administered, and they don't necessarily expel the virus from the nose. For that, you require what are called mucosal vaccines, which are still under development. So there are different components of immunity, but as Dr. Jameel said, we actually should not really worry too much about reinfection. Most of the people can combat reinfection provided they have a reasonable memory of what has happened in the first time. And these are relatively anecdotal reports. But
Yes.
Unless we understand that there are different forms of immunity, we will fail to understand why this is happening.
That also brings me to the fact, Professor, that there has been, even in the Western press, a sort of shotgun reporting of everything scientists and doctors are saying. And it has been said that a lot of these papers are not peer-reviewed and so might be slightly premature, which brings me to the next question I want to put before the panel. Reports of permanent or long-term damage to the lungs and the heart, reports of the virus affecting the brain. Is this something that you are worried about, Dr. Mohapatra? Is this something we should be worried about, that there will be long-term damage to some people in their lungs and their heart?
Definitely, yes. And the fact is that we have to be really worried about the fact that we are not knowing, despite all the research going on and all the stuff, we are not knowing different things with that much conviction to say that this is actually something based on which rest of the research can progress. Just like it took quite a long time to understand what is the pathophysiology of this disease, and while coming to this embolism part and all this, starting from this cytokine storm and the rest of the process, it took quite a few months of time for us to ensure that this is something based on which we will be planning our next of the management and other things. Now there are reports, some of which you are showing that there are different long-term impacts on lungs, heart, as well as brain that we are talking about. And some papers, which definitely those are in preprint or something, but they are reporting that the CT findings showing some long-term, sometimes irreversible damages in the lungs for for the patients who have suffered from this, even for those who were mild symptomatic. Now, the fact is that the damage that we are seeing right now, it's also probably we are seeing the immediate damage. And many of those, whether they are going to be permanent or not, they need some kind of more numbers to understand what is happening there. One point with Professor Reddy said, I want to mention that we have to be careful about how we are reacting to all this information. Just like this is definitely anecdotal, and this is definitely only two in the all the reports where the gene sequencing could identify whether repeat infection can happen or not. But that should not give somebody a false sense of relief that I have been infected, so right now there is no requirement of any kind of protection for me or anybody around me, that because I am now protected by antibody. And just like that, having something where certain CT scan is not showing some change right now, whether in lungs, brain, or heart, or showing something where we are seeing severe changes, that requires several other multifactorial pathways to be addressed, just like what was exactly the situation before the virus did affect that person. We need to understand that when the damage in the lung parenchyma or lung alveoli that we are seeing, are these the typical impact of the viral impact on those cells and all those organs, or it is something which is the aggravation of some underlying ongoing pathology which is there. And it has already been proven that those kind of underlying pathologies actually much more aggravated in presence of this kind of viral impacts. And one more important part that is there, that we don't have sufficient numbers for each of these to understand that what are the long term. I mean, long term is actually itself a relative term, but definitely it's a dangerous virus, and it's actually really something where we not know much despite of doing a lot. I'm not saying that science is not robust enough to take humanity out of this, but we need to understand that we have to have a system of building on our information to design new research to come up of these aspects. And I'm sincerely worried about what long-term damage COVID is going to do, not only to the body, to the health system in countries like us.
Why do you say to the health system?
Because
Won't this lead to people focusing more on health?
Now the point is, that's a good point, that this is something which has brought us from buying land from March to having more funding in health. But the fact is, uh, what is exactly happening to the person who was supposed to have dialysis yesterday and did not find a particular hospital where he can be admitted at the same time? So if we, I am not talking about anything, basically COVID is causing three kinds of harms. One, to the patients who are suffering, who are getting infected or developing the disease. Number two, who are not being infected, and that's, but at the, because of the processes through which they are required to be going, like think about the doctors. They are under a huge amount of mental pressure, which is an overall impact on their health. And this is for the whole health system and also people around us. Everyone is going through a lot of stress. It's more than 9 months. And this is going to impact, this is very likely to impact the life expectancy and other kind of things if it is not taken care of early, because this is a huge impact on the overall health. And the third thing is, aside COVID, every other illness has their own impact on the health system and overburdening the system. Now, given COVID has taken the toll on the doctors, on the system, on the HR, on different supplies, and overall the rationalization and system delivery of the health system, it's completely chaotic. Right now, I really don't know if some of my family members in my native state, if get sick for some other disease, where they are going to go and how. And that this is something where a complete mayhem is actually being observed for among the general people. And this is causing something which is actually an insensible loss, because we are talking about death due to COVID, those which are reported. What is happening to the all-cause mortality? What is actually happening to the disease which could have had a 5-year survival rate of something, which we will see after a few months or something have changed? The patients who were undergoing chemotherapy and lost their schedules for some reason, sometime the health facility being overwhelmed with COVID. So these kind of things are actually overwhelming the health system, and definitely it has made health more important, but we need to learn from it. Instead of like sensitizing something by saying something has happened somewhere, some drug is working somewhere, etc., we need to understand that whatever we are working on to address this right now, we could have had this anytime. We didn't hear anything after Spanish flu like this. What did we do in these many years? We always talk about disaster management, how prepared we are. Disaster preparedness comes before disaster management. So the point is what I'm trying to make. We need to ensure that we have a health system rationalization process and something in reserve, that whenever this kind of situation happens, we have our mechanism and machinery to have our capacity judiciously utilized, and it's not something which is always a knee-jerk reaction.
In fact, I just want to pick up what you said about the non-COVID patients and what they're going through. There were reports also that pointed out that in India, a lot of the public service healthcare that we were doing completely stopped during the lockdown, including the distribution of birth control pills, the distribution of HIV pills that the government normally does. People didn't get access to those services, apart from those who were relying on public healthcare for things like dialysis and heart treatment and things like that. And I'll go back to Professor Reddy for this. Professor Reddy, how deeply do you think patients, non-COVID patients, have suffered, and doctors and nurses and hospital staff who, when they started, were donning the PPE saying we're going to get through this, but nobody saw that it would go on for 6 months?
Yes, this has adversely affected other health programs. In fact, the public health emergency or the public health disaster which COVID has brought has now resulted in a secondary public health disaster of other conditions being neglected badly. And that's going to have a price in terms of lost antenatal checkups, missed immunization programs for children, as well as lack of attention to a number of other issues. Institutional delivery rates have come down. Care of hypertension, diabetes, and kidney disease, and even cancer chemotherapy, all of that has suffered. Surgeries have suffered. So this actually tells us, firstly, that unless you have a competent and compassionate health system, which is providing efficient and equitable care in the steady state, you cannot expect a surge response in the face of a public health emergency, which can cater to all the needs. It is unable to cater even to the needs of COVID, and it's happening that other conditions are being neglected. So this is a lesson that we must actually build a much stronger health system, which is capable of responding to all of these without sacrificing the routine healthcare needs. And as far as the nurses and doctors are concerned, again, our health workforce is grossly understaffed and therefore now overstressed during the COVID phase when they are having to work well beyond the call of duty. In fact, even when you look at doctors, nurses, and auxiliary nurse midwives put together, the WHO in 2016 said we need to have 44 health workers of these categories per 10,000 people. We have 22. We have just half the number. Therefore, with very under-resourced and sometimes under-skilled health workforce and poor infrastructure, we are now fighting a battle against a major public health emergency, and other health conditions are suffering as a consequence.
I just want to read out a few messages that are coming in from our viewers. Ravi Teja says there's fatigue visible in government and healthcare agencies as well. We don't see press conferences, and that's true. When we were at 1,000 or a couple of hundred cases, in fact, the health ministry was having daily press conferences, but we haven't heard from them in weeks now. We are at 46 lakh cases. Peter D'Souza says, keep it up. Thank you. Anurag Gola says, thumbs up to us. Reinfection is a reality. Would the vaccine even work? And I am going to come to the vaccine next. Utkarsh Singh says, would love to know the panel's view on testing guidelines. A person next door to me tested positive. People came and tested some random neighbors, completely ignoring houses that were 2 doors down. Is there a quota that they need to fill? Tamanna Jagga says, thank you for the story. Nikita Bansal also supporting us. Mahe and Pratik Soni supporting us right now. So 2 questions popping up from there. One is the vaccine and second is testing protocol. If I may ask Dr. Jameel about the vaccine, it was disappointing to note that the Oxford vaccine, as it's called, has been paused because they had some unexpected outcomes. If you look at right now, you said there are 200 different vaccines being worked on in trials across the world. How much longer before we see a vaccine? 2 months, 3 months, 6 months?
Let me just answer this in 2 parts.
Please.
Was the Oxford vaccine pause disappointing? In a way, it was disappointing, but in another way, it was actually very reassuring. It was reassuring that we are doing the trials correctly. The data safety monitoring boards are doing their job as they're supposed to be doing. And we're not taking shortcuts just because somebody has to go to an election in November or anything like that. So it's actually very reassuring that large companies have also come together and said that we're not going to succumb to any political pressure unless we are satisfied that the vaccine we are making is safe and efficacious. We're not even going to go to the regulator for permission. And I think that's a very reassuring thing. That's a very mature response because companies have invested huge amounts of money into this. So let's not be disappointed because we are being careful. And at the end of the day, the vaccine has to go in a large population, a population which will have people with all kinds of comorbidities, all kinds of health conditions. And we don't want a vaccine to actually cause further aggravation in their health conditions. So what is being done is absolutely right. And I'm not disappointed. I'm actually encouraged and I'm reassured. What was your second question? Sorry.
How long before we see a
How
vaccine?
long?
I
How
know that
long?
distribution of the vaccine will be a big
Yeah.
question,
So
but timelines.
the other thing to understand is that there's much more to a vaccine than simply than doing a phase 3 trial and getting an approval. There are little things to be concerned about. How much vaccine can you make at a given time?
Hmm.
Uh, it is estimated that the global vaccine manufacturing capacity is about 8 billion doses annually. Now, that's roughly equal to the population of the world. The couple of facts here is that all this capacity will not be used for COVID. Whatever COVID vaccine comes, it may need more than one dose to be effective. And all this capacity cannot be utilized at the same time. So we are essentially looking at something around maybe 2 billion doses to begin with in the first lot. Uh, and the politics of vaccines that's going on right now, companies are selling advanced orders to rich countries. So things have to be really equitable to get people's confidence in vaccines.
Yes.
Uh, so if you're pinning me down as to when the vaccine would be available, I would say that the earliest we will see vaccine get into the arm of uh, common person, or not even a common person, maybe a healthcare worker or a security, would be maybe the first quarter of next year. Those of us who are lucky enough not to have any other morbidities or are young enough will possibly wait till sometime later next year. Uh, but again, this is the fastest a vaccine has ever come.
Yes.
I don't have to remind people that in 2003, when SARS came, it took 20 months to develop the SARS vaccine, and by that time, the disease was gone. So again, I'll harp on the same thing that the power of science is really very visible in vaccines. Yeah.
I just want to remind our viewers that under normal circumstances, it takes between 10 to 15 years to develop a
Yeah.
vaccine, because that's the kind of trial period they use to figure out the long-term impact of it and to figure out the dosage and figure out the efficacy of a vaccine. So this is
In fact, for COVID vaccine, it's been said that if things were done at the regular speed, it would be 2033 when the COVID vaccine would come.
yes. We have a very interesting question for the panel from Nina Picardo, who's written in saying, we keep hearing that our hospitals are understaffed. Why is this? In a country of 1.2 billion people, with so many Indians dominating intellectual fields globally as well, why do we not have enough doctors? That is an excellent question, because we have everywhere in the world, we have brilliant doctors of Indian origin doing remarkable work. Why is there a shortage in India? Professor Reddy, do you want to tackle this? This question?
Sure. There are two reasons. Firstly, I think we have underinvested in health sector as a whole, spending only about 1 to 1.2% of our GDP on health, which means very many areas of health, including building up a competent health workforce, have actually taken a back seat. But coming particularly to doctors, there has been some sort of a vested interest for several years in restricting the number of medical college seats and postgraduate level as well as undergraduate level. And the medical colleges are mal-distributed, with more than 60% of the medical colleges being there in the southern states and in Maharashtra, and rest of the country having very few medical colleges, especially central, northern, and northeastern India. And the seats were kept very limited because, as has often happened even in other countries, there is an attempt to try and put a price on each medical seat, and so that each doctor, while wanting to graduate, is going to pay a fair amount of capitation fee to the private medical college, or even after graduation is going to command a much higher price in the market If there is a flood of doctors, obviously each doctor is going to get less segment of the pie. So because of these reasons, artificially, the number of doctors also has been constrained. Now the Medical Council of India, under the new governance, has increased the number of seats, and we are hoping that there will be more medical colleges in underrepresented states, and some of these asymmetry and disparities would be corrected. But these are the two reasons. But even the production of more doctors and nurses is not going to help unless we actually put in more money into the health sector at all levels and strengthen our health system, primary particularly, but also secondary and tertiary.
Doctors Jameel and Mohapatra, do you want to comment on why we have a shortage of doctors in this country?
We're always going to have that as long as our whole culture does not incorporate the fact that health is a service acquired by right, birthright, not a commodity. As long as health will continue to be a commodity, we will always have this problem. And that is not unique to India. It is unique to the countries where we have these kind of things actually perceived into the system. We can completely deal with it by considering health as a commodity if we are that much true with making business out of the actual expertise and all those stuff. So it's a mixed kind of thing when private sectors are always considered as the areas where people will go if they can afford, whereas the government services are only available the time when people who cannot afford the private sector will go there. This kind of imbalance and equity, in lack of equity, continuing into the system, and the more the other kind of adjustments like the public-private partnership and all other stuff and the other sectors coming into it, actually widening the gap, ended up in this situation. This is exactly what I was referring to when I said, what did we do in terms of our preparedness? Having our seats, what Professor S right now said, that what were we actually doing about having our doctors prepared for something by having more seats and by having more number of facilities like clinics. There are different kind of things which has gone. We have seen in cities that small clinics and small nursing homes disappearing, and we are having the public sector and private sector widened gap. People who go to the public sector cannot even think of the private sector, and people who go to the private sector, they are actually not kind of ever thinking that any treatment is possible in the public sector. Now all these things ultimately disbalances the system. We have to have more funding, and I mean the more budgetary focus on health, and as a whole health needs to be considered as a right, as a service of the state, and as long as we are not reaching somewhere there, it will continue to happen like this.
Dr. Jameel, just to pull this point a little further, when I was going to college in Bangalore, I had a lot of friends who were at the St. John's Medical College, brilliant young people who are all overseas now, cardiothoracic surgeons at hospitals in the US and the UK. Why do our brightest doctors leave us?
Pardon me?
Why do young doctors, after they finish their
Right.
medical college, leave and go overseas?
Maybe they find a better work culture there. Maybe they find better opportunities there. It happens in many other sectors also.
Yes.
IIT engineers go overseas.
True.
I did my post-graduation at IIT Kanpur, and out of 14 people in my class, 12 went overseas right after our post-graduation. And after a few years, 3 or 4 of us came back. The rest are still there. So it's not just happening to doctors. It happens in various other sectors. So maybe we need to create better working conditions for all those young people in whom we have invested,
Yes.
in which the taxpayer has invested, but we are unable to provide them the kind of satisfaction. Some of it, of course, is greed, but a lot of it has to do with satisfaction.
There's obviously across the board, as far as science and technology and research is concerned, there is a massive brain drain of people who tend to go overseas. But I suppose the real question that we have to ask finally is what Sham BP has said. When do you see cases coming down in India? Current situation every day seems to be higher than the previous day. This is the operative question, really. Sham, it's an unfair thing to ask our panelists because I don't think anybody can correctly predict. But I'll turn the question around a little bit. What needs to happen for us to see these cases coming down? Or is it a sense of resignation saying, hey, you know what, we're 1.2 billion people, this is going to happen, it's going to override, and then we're just going to have to see it through to the other end? Are we resigning to the current situation? Professor Reddy?
Well, there are 3 fire escape routes by which we can get out of this.
Of the question or the virus?
Not the question. Of the epidemic, of the pandemic. Not of the question, not of your show. Well, the 3 fire escape routes are, firstly, a vaccine, which we are not sure of in terms of an effective and safe vaccine, whether it will arrive and when it will arrive, that we do not know. The second is the so-called herd immunity, which we do not know whether the threshold is going to be 50%, 60%, or 70%. And even if a particular city does reach that magical threshold, the people who are not exposed and immune and who are protected by others who are immune and are providing a protective cordon, those susceptible people, when they move out into another city, they are still vulnerable, very much vulnerable. So it's herd protection, it's not herd immunity. So for all of India to get that magical 60% immunity, or all of the world to get that magical 60% herd immunity threshold, is going to take a long, long time. So I don't think we should lay our bets on that at the moment. The third is the virus itself may grow less virulent over a period of time. It happens through evolutionary biology. The virus is fairly innocuous when it resides in the forest animals, but when it gets a huge human population to travel in, and the virus does travel with people, and it celebrates with the crowds, and therefore it tends to actually become more virulent and very infectious. But if we actually limit its spread as much as possible by physical distancing, by masks, and taking all the precautions we need to take, firstly, we slow down the transmission. And then in order to actually perpetuate its own species, the virus itself will tend to become a little less virulent and learns to cohabit with the human population. And that's what has happened to other coronaviruses too in the past. So these are the ways in which we need to look at it. But certainly, at least till we are sure that we are past the crisis till sometime in next April, because we still have the winter to come.
Yes.
We have to maintain our precautions in terms of physical distancing, hand hygiene, avoiding large crowds, especially in indoor places. Only if we change our behavior will the virus change its behavior.
So both literally and figuratively to do with COVID, guys, winter is coming. Follow the SMS formula, which is the only vaccine that we have available, which is you sanitize, you wear your mask, and you maintain social distancing. That's all we can do at this point. This thing is still out there. It has not disappeared. It has not gotten weaker. You've not gotten stronger. Nothing magical has happened in the last 2 or 3 months. What has happened is that governments have realized, both state and center, that the economy needs to start clicking, otherwise we're in deep trouble. So they've opened up for the economy, not for the virus. The virus is now up to us to fight, to look after our families. And remember, as far as this virus is concerned, you are as strong as your weakest link, which means that everybody needs to stay safe for you to stay safe. Do not leave your house unless you absolutely have to. Gentlemen, it has been a pleasure to have this conversation with you. I promised that I'd let you go by 9 o'clock. Thank you so much for being so patient and answering all of our questions. We appreciate the learning and your time. For our audience, thanks for watching. Good night.
Thank you.